Hello, good morning. Phase 1 complete, managed to not fall up the steps, done that before. It's lovely to be here today. Lots of people, delighted to have been invited along. Trying to follow Katie there, I thought it was a wonderful presentation, really interesting. So we'll do what we can. And my thanks to Flora as well for organising this and also for putting up with the lateness of my slides, which are not in the same format as everybody else's. There's a reason for that. But we'll continue. So I'm Dr. Stephen Smith, just Stephen most days of the week. I'm a clinical psychologist. I've been working at the Penumbra Milestone ARBD unit for 5 or 6 years now. The unit is a collaboration, and quite a unique collaboration between the NHS, City of Edinburgh, and the third sector organisation, Penumbra. It started back in 2014 in response to a recognised population of people who were coming through A&E largely, who were coming in with head injuries, having fallen over or being in fights, that sort of thing, or gastrointestinal problems, but for all of whom the key issue was chronic and excessive alcohol use. There's a wonderful medic called Lynn McCallum who just noticed this pattern and then set about doing something about it, and she was incredibly persistent and finally managed to get people listening, and then somehow managed to get funding, and then got people to agree to collaborate. Quite an incredible thing. And so what we have now is a 10-bed residential unit based in the sort of Oxgangs area of Edinburgh. We're on a 12-week programme for people with a diagnosis of alcohol-related brain damage. And we work in this sort of assessment, rehabilitation and community integration or reintegration model. And I'm going to take you through the sort of nuts and bolts of ARBD and the unit, and then pass you over to Amy to tell you about an incredible piece of work that she's been doing in the community. So hopefully it'll flow quite nicely. Just thinking about what ARBD is. Don't know how aware of it you are. It is brain damage caused by alcohol. And the damage, I don't know if anybody's seen the cards desk out there. Cards in? Where are they? There you are. Lovely to see you here. So alcohol-related brain damage, it's an umbrella term. It covers lots of other diagnoses, and that's one of the issues. It's quite difficult to pin down precisely what it is. It's caused by chronic use of alcohol. By that we mean usually over 5 years of heavy drinking, which can be different for different people. We've got to keep in mind that everybody's brain is unique. But in general, we're looking at more than 35 units of alcohol a week. In reality, the people that we work with, I'm sorry, I'm looking all around and people are going, oh, that's me. In reality, we work with people who are probably using more than 100 units per week and have done for quite a long time. And it's important to keep in mind that those people are using alcohol to that level usually for a reason. The reason is often, I'd say about 90%, not just me, the research indicates, but 90% have had some sort of trauma in their childhood or adulthood. So they're using alcohol to manage that, become addicted, use more, and this causes brain damage. The sort of damage that we see, again, it's a spectrum, and so it ranges from quite mild to very severe. At the mild end, and the first sort of signs are difficulties with planning and organisation, not being able to do things that you used to be able to do, multitasking, maybe going into the supermarket and forgetting what you were there for. And it progresses to the point where immediate memory, so that memory of what I said at the start of this sentence, can be very decayed. Again, I'm just wondering how many of you are now thinking, what did he say at the start of that sentence? But it can be decayed to that level that it's very difficult to recall what's being said. It's an impact on delayed memory, which is anything over about 20 minutes or so. So you can see that that will have an impact on social engagement, ability to engage with services, lots of irritation and anger when people say, I told you that 5 minutes ago. Now, this isn't just about ARBD, of course. Those symptoms and signs run across many different diagnoses. But these are the early signs that something's happening, going into those very clear signs of cognitive impairment. At the top of the spectrum, I guess, we're looking at people who really can't remember your name after you've told them it 3 minutes ago, who are unable to sequence and plan making a cup of tea, who are unsafe to be living on their own. We tend to work with people at that end of that spectrum. We're just setting up a new training team to go out into the community and train people to recognize people at that end of the spectrum, because the progression is very, very clear and very simple. So we want to catch people as early as possible. The unit itself, as I say, we work mostly with people at the severe end of this spectrum. NHS provides clinical lead psychiatrist, myself, Amy, physiotherapy, and we have GP partners as well. Penumbra provide the sort of infrastructure and the day-to-day running and recovery work that goes along with that. And the City of Edinburgh provide a dedicated social worker. What we'll try to do is cover everything, have a holistic approach to each person's problem or presentation. The service provision, we've sort of understood it in this way. We've got, the features are that it's collaborative, it's shared care. So every one of those organizations has their own pathways and procedures, but we share information so that it's all under one umbrella, so nothing gets missed. We do holistic assessments. We front load expertise early on in people's journeys. Now, people will come to us from the acute hospitals. That's where our funding comes from at the moment. We're very much looking to develop into the community services as well, to work alongside our colleagues here. But at the moment, we take referrals from acute hospitals. That's where our funding is. So we wait lots of expertise early on to get the assessments right and to develop a plan for each individual. It is holistic. We think about people's physical, mental, and social health. And it's integrated, as I said. We think about assessment, rehabilitation, and their move back into the community. And that's where Amy will pick up some of that story as well. Some issues about identification of ARBD. It's often in primary care settings with physical health problems. So people will go to their GP having fallen over or having GI problems, gastrointestinal problems, a range of physical health issues. And it's often missed that there's possibly ARBD happening at that stage. So we usually see people at the later stages of brain damage. It's called brain damage because that's what's happening. There's a direct neurotoxic effect on the brain, partly through lack of thiamine, which is quite easy to recover from, but that long-term use of alcohol causes specific damage to the brain. People present with, well, they're often inebriated when they present to A&E, and so their impairments are assumed to be acute intoxication. People aren't thinking, is this what you're always like? Are there long-term effects without the alcohol? And it's understandable. I'm not having a go at the A&E. We have wonderful relationships with our colleagues in the hospitals. It's just difficult to keep in mind that there might be long-term damage here because you've got somebody in front of you who's intoxicated and injured. But there's a training need there as well. Another issue is that there's often well-preserved language. So language doesn't tend to be so affected. People can still talk and engage socially. And so it's quite a hidden issue. And it's only when we start scratching beneath the surface, when you start asking the same question a couple of times, when you see people over a prolonged period, and by that I mean maybe a week, that we begin to see the deficits that are very, very clearly there. And it's often ARBD isn't number one in people's understanding of what's causing these deficits. There's usually 2 or 3 things that people go through before that, again, understandably. But when we think about the prevalence of ARBD, it's hard to understand, it's hard to pin down. But what we reckon at the moment, that in the general population, it's probably about 1.5%. So I'm just looking out here, I'm not making any assumptions, but in a room full of 150 people, we've got at least 1, maybe 2. Independent drinkers, that rises to somewhere between 30 to 35%. So if you were all dependent drinkers, again, not suggesting you are, but if you were, then you would be sitting next to somebody with ARBD. And so would the person sitting next to you, possibly. Let's think of it that way as well. So there's a lot of it out there, and we're not picking up as much as we should, because we can do something early if we can. So going back to that model that we have of assessment, rehabilitation, community reintegration, we do lots of assessments because we want to understand what are the deficits and what are the strengths. What can we work with? So physical, cognitive, psychological, psychiatric, and occupational therapy assessments all happen within our 10-bedded unit. And that tends to happen within the first 6 weeks of people's residential stay there. Everybody has their own room, it's all individual rooms with a lovely communal area, some outside space. So everybody has that assessment so that we understand what are the deficits, what are the strengths, both in terms of their psychological, their physical, and their social health. So it's very much a holistic approach. We have a groups program which encourages people to socialise and talk about what's going on. There's lots of different groups, and each of them target different things. A large part of what we target is emotional well-being. And again, we're pitching this at the level of people who struggle to remember sometimes what you said 10 minutes ago. So there's lots of repetition. The staff are fantastic at being able to pick up on key themes and keep it in mind. There's an everyone at every group sort of approach. It's a residential unit and people are there, they're all encouraged to come and engage, of course they are. We do recovery, memory, emotion, healthy living, creativity. So we try to cover the person as a holistic unit, as a holistic person. There's lots to think about. And everybody has their own interests and strengths, preserved strengths. So we try and pick up on that and build a program around each individual. And then we think about community reintegration. And all of this, again, ties in with the assessment. What are the strengths? Where are the deficits? What can we be adding? How can we help this person get back into a life in the community, which is hopefully free of alcohol, but not always. How can we help? So we think about mobility, employment, where that's appropriate. What community, what supports they'll have out there. And again, this is where our colleagues and cards are fantastic. What family supports and structures need to be worked on while people are in the unit and afterwards. And where are they going to live? Often people come to us from a really impaired place where their housing has deteriorated, often is simply untenable and unsuitable for their needs given their cognitive impairments. So all of that happens while they're in the unit with the idea that they move on from there. To help people do that, we've got a couple of toolkits which are freely available. If anybody wants to know more about those, give us a shout at the end or sometime at lunchtime or something. And then I'm going to pass over to Amy to talk about one of the things that happens in the community. A bit of time for questions later on if anybody has that. Amy?
God, I didn't expect so many faces. So I'm the OT that's based at Milestone, and recently, last year, we got extra funding to do a wee bit of more work in the community as a follow-on when people were leaving Milestone. A wee bit about occupational therapy. A common misconception is when you say you're an occupational therapist, people think you're going to get someone a job. But that's not always the right thing, because occupation for us basically means any activity that you perform. And we look across 3 domains, which is self-care, productivity, and leisure. So that's what I do with the residents. In the unit in Milestone, basically my job is to look for their occupational meaning. You know, for whatever's happened in their life and alcohol's kind of taken over, their main occupation was drinking, and then all of a sudden that's removed, and it's looking at what are we replacing that with. So we kind of go through a process, and kind of theory-wise, we look at what they're doing, how they're doing it, who they are, and who they want to become while they're going through that process of change. I don't know if Stephen covered this, but just in terms of recovery, 75% of people with ARBD do make some recovery. Did you say that? I can't remember. So 25% of people can make a complete recovery, 25% make significant, 25% a slight recovery, and 25% make no recovery. So the group, why did we kind of decide to run the group? So when people come to Milestone, they're there for a 12-week period, roughly, and they're inpatient, and it's quite intense rehab. Then it gets to the kind of end of their stay, and it's all of a sudden you're going back home. And that can be really daunting. It can be quite scary, and quite isolating again, leaving what's been a really supportive environment. So we're kind of looking at kind of bridging the gap. And across in Glasgow, they've got a dedicated specialist service within the community, but Edinburgh kind of runs a bit differently at the moment. So we thought, right, we want to continue working, but also doing it in a community venue, pull away from Milestone and do it in an environment that's not related to inpatient stay, but still continued rehab. So the overarching goal of the group that I run, which is the Guided Self-Discovery Group, is basically to promote and enhance occupational balance. So basically what we're saying is if you've got your self-care activities and you're engaging in those, you've got leisure pursuits, you've got meaning and purpose in life, and productivity, you're going to have an occupational balance. Or if there's any of these out of sync, it can have a knock-on effect of your balance. So the group format is we run the group at the art galleries, the portrait galleries on Queen Street. They've very kindly given us the room for free to use, along with cards as well, use it there. We run 8 sessions, and it's for any person that is either nearly being discharged from Milestone or half went home and then are starting to struggle and they want to pick up a wee bit of support. So they're offered 8 sessions, and it's a closed group, so it's the same people, same faces every day. And really the theme, we run on themes to do with their self-identity. We've got Sam, she's a freelance artist connected with the art galleries, and she comes in a few sessions and does more creative activities in relation to the things that we've been chatting about. So this is a wee bit of work just to kind of show you what they've been doing in the group in terms of their self-identity. So this was the first project in the group that we ran, and this was Willie, and this was kind of to show his journey from where he started to where he sees himself now in terms of his self-identity. So this is a picture. Willie is actually under his hoodie behind this wolf in this photo, and he was really small. And that's how he viewed himself. He was really, really small. He then went to Milestone, and he started to feel a bit bigger. There was more purpose again in life. He wanted to be better. So now he shows his face, and he gets up every day, and he engages in self-care. He goes fishing, he volunteers, and he likes who he sees in the mirror. So that kind of journey was kind of worked throughout the 8 sessions that we did at the group. And then we've got Eduardo. This is another member of the group. Eduardo originally, before going to Milestone, couldn't even look at the camera. He did not like who he saw, so he had to show his back. That's who he was. In his journey to Milestone, now this gentleman had been in Milestone twice, because it's not always really easy, you know, changing is a big deal. So this is kind of to show sometimes was good. I was really far away, then I was climbing back through the frame. So then he's at a point now, 6 years later, I'm right through the frame, I like what I'm doing, I'm engaging in all my self-care activities, I enjoy going, I'm driving again, I'm doing a college course, despite my memory difficulties, I'm still moving forward. This little lady, Margaret, this photo's not great, but you can see before Milestone, her hand covering her face, I don't want to be seen. So during Milestone, I'm just going to peek my eye out, because I'm quite happy to be seen again, to look at me. I've got my crown and my wig on, and I'm loving life. I'm getting up and I'm showering every day, and I'm taking care of myself. And her little quote, I can and I will. So some feedback, we gather some feedback. So at the beginning of every group, 8-week block, they fill in the Rosenberg Self-Esteem questionnaire, and at the end, and you'll see from the feedback that all participants that completed, one at the start and one at the beginning, showed improved self-esteem, or the way that they viewed themselves. They also, this was a specific OT tool, but they showed that their occupational participation in their activities of daily life had improved from thinking about where they were before to where they are now. And then in terms of their feedback, do you think the participation in the group session was beneficial to your recovery journey? 5 being the highest, we got a lot of high scores. A lot of the time they talk about feeling judged and not wanting to talk about how they got this condition, but within that supportive group and a shared understanding, it's the one place they come and really open up and talk about it and make plans for moving forward. In terms of enjoyment, again, they've rated the sessions really highly. And this is just one of the pieces of artwork that they completed. They then made and took to Milestone and presented to the current inpatients to show kind of inspiring story of look where we are now type thing. So that project was called Where We Are Now, and that's just a few quotes from Willie. I used to look in the mirror and not like what I saw, and I look in the mirror and think, you're no bad. And then Andrew, I never thought I would ever have the confidence to walk into the National Portrait Galleries. I don't know if anyone's ever been in, but it's massive, it's beautiful. And he thought, I couldn't go in there. Now he takes himself in for a coffee. And Margaret, this group's the highlight of my week. So this was a speech written by one of the guys that came to the group, which he delivered to the inpatients at the unveiling of their work. So from Andrew, on behalf of the group, I'd like to thank Amy and Maria for the past few months, and also the Portrait Gallery for the kind donation of the premises, and for the artist Sam, who's also been very helpful during the sessions she attended. I personally have found it very interesting and enjoyable in those cold, damp Monday mornings. I think we all agree that this group would benefit all by continuing. I think it is true to say what fantastic things we have on our doorstep here in Edinburgh, but fail to appreciate this a lot of the time. We are all very proud of what we have achieved in the making of this piece of artwork. It says, life can move forward and find new challenges which are both rewarding and enjoyable. I hope everyone who enters the door of Milestone does not fail to notice our masterpiece. I think it would be hard not to. And when it's hung in the Tate Gallery in London, I hope nobody throws paint over it. And that was a very proud moment for this man, getting to do his speech in front of the Milestone residents. And this again is just an example of a piece of work, again by Andrew. This was his portrait, which is called A Blank Day at the Supermarket, Hate Shopping, I Would Rather Be Playing Pool. And this was in relation to, he needs to shop because he needs to eat. So he does do that task, but his leisure pursuit is pool. So he puts his face on and he goes to the shop, but he's thinking about playing pool. And just kind of final thoughts, this was another bit of work in the piece of work by Eduardo in the group, and he named it "It's in Your Hands" when he was talking about his recovery journey with ARBD. And kind of final thoughts for the groups were, we don't want to drink, we want to remain abstinent, we know it helps. We know we want to eat well, that helps. Our homes, they're tidy, they're organised, they're calm, they're stable. We've got structured daily activities, whether that's groups, meeting befrienders, going to the shops, and they accept and support encouragement. And they've got their memory and orientation cues, like their diaries and their calendars and different things to keep them going. Is that the last? Yes, that's the last slide there. But yeah, thanks.
Thank you. Just asking if there's any questions for Stephen or Amy. Yeah, one over there. Getting my steps in today.
So thank you so much. It was absolutely fascinating. My name is Karen. I've got 2 questions, if that's okay. So first one is to Dr. Smith. If you notice any comorbidity with ARBD, with other mental health disorders?
Lovely question. Yes, most of our residents will also be on some sort of psychiatric medication for anxiety, depression, that sort of thing. So they are very, very commonly comorbid. We also know that alcohol use is a very common way of coping with other sorts of head injury. So there's lots of crossover there, absolutely. Does that answer your question?
Yeah, that's
Yeah.
it. I was just curious about the nature of the service, and the services it provides. And the second question is about the help provided within the community. You were talking, you're educating community to be able to recognize ABDR better. So have you met many challenges regarding the culture differences, especially like the pub culture within Great Britain? Especially in Scotland, we're very focused on pub culture and drinking, and it's been an everyday, normal part of our lives. So have you met any like cultural backlashes from it, and find it difficult to educate people on
it? That's a wonderful question, very in depth, and I'm very happy to talk to you afterwards if you want a bit more. Just trying to pick up on the sort of points you're making there. There's probably, we talk about the prevalence of as being roughly 1.5%. We're pretty sure it's much higher than that. It's simply very difficult to get hold of enough people to generate that sort of statistic. There's some research which is telling us that it is far more prevalent, that there are many more people. Sorry, I'm not sure I'm answering your question. I'm now talking about prevalence. Oh, that's okay. But that's where we are. We know that there's many more. We know that there's a high correlation with other sorts of physical and mental health issues. We simply don't know how much, really. We're in the process of starting, in fact, we're just starting next week, a new training and development team, which is going to be looking at some of those questions. So, I mean, just thinking about the audience in here, I'm not saying any of you have ARBD, I don't know, but certainly you'll be working with people who are also using alcohol to cope with other issues. So if anybody wants a little bit of training on what ARBD is, come and give us a shout sometime during the break.
Thank you for